We all know that high-dose melphalan has been introduced by two famous British myeloma specialists in 1983. They treated 9 patients, and most of them responded. And so at that time, G-CSF was not available. So it was still a risky procedure, but with the introduction of G-CSF, stem cell transplantation has become a very safe treatment and very effective treatment. Today we have the issue how to collect stem cells, because we all know that CD38 antibodies, which are now introduced in all first-line protocols, have a negative effect on the stem cell yield. So probably you need one needs plerixafor in addition to G-CSF for stem cell priming, at least in about 30 to 40% of your patients. And then you have enough stem cells. And what has been done in the past was that people tried to increase the efficacy of high-dose melphalan, which is 200 milligram per square meter, by adding different drugs like busulfan, bortezomib, idarubicin, bendamustine, ixazomib, and so on. But none of these efforts really was superior to high-dose melphalan, 200 milligram per square meter, in people with normal renal function and no significant comorbidities. So that is the standard. The question is then, nowadays it's routine that it's routine, but we have to be careful with this saying, because routine in Europe, it is not so much a routine in the US, that stem cell transplantation is standard in young in patients available for this procedure, because you increase the depth of response. After induction therapy, you increase the number of MRD negative patients. But we have to look at the data. When you compare stem cell transplantation with chemotherapy only, and there are two big studies. One is the IFM 2009 study, and the other one is the determination study, which has been conducted in the US and recently been published. So when you look at the general outcome in terms of survival, there's no survival benefit between immediate stem cell transplantation after induction and stem cell transplantation and progression in those who did not have stem cell transplantation initially. The stem cell transplantation at progression is something which is difficult to achieve, because many patients are not willing or are physically not fit enough. So the benefits in terms of overall survival are meager or not there, but what you obtain is a much longer progression-free survival. And that may be important for many patients, no question. And so it is standard, at least as mentioned in Europe, but not in many other parts of the world. And then the question pops up, is double transplantation needed in patients with high-risk disease, so with high-risk cytogenetics? And the data supporting that are rather meager. There is no improvement in overall survival when you compare double with single transplantation in most studies. But there may be a small subgroup of patients with high-risk cytogenetic high-risk disease who benefit from double transplantation. That was also seen in an American study called the Stamina study. Now, I think these are the most important issues which I wanted to convey during the professor session in Rio de Janeiro during the forthcoming IMS meeting. But I'm open for questions and happy to respond to those.